So welcome to our ninth webinar, and that is on calcaneal fractures. We have top-notch faculty from the UK. Dr. Rajesh Kakwani is a foot and ankle surgeon and a consultant in Northumbria healthcare system in the UK. And it is a pleasure to host him for our webinar. He's going to talk on calcaneal fractures, and I invite Dr. Rajesh to share his presentation. Over to you, Dr. Rajesh.
Hello, good evening. The talk today is going to be on calcaneal fractures. Now, if you are applying for the FRCS Orth, the calcaneal fractures would generally come in your trauma viva section. So we'll start trying to talk about that way. One second, let me share my screen. Sorry. Okay, so first of all, welcome everybody. I'm Rajesh Kakwani. I work in the northeast of England in Newcastle. I'm also in the scientific committee of the British Foot and Ankle Society, and I'm a faculty for the AO trauma course. Now, conflict of interest, I've got none. I do want to acknowledge the help of both us, AO trauma, and my colleagues. Now, the typical scenario that you will possibly one of a young, fit gentleman who is in an IT professional, normal BMI, non-smoker, who's had a fall from a height, and you'll be shown x-rays of similar nature, where you would see calcaneal fracture, which is likely to be displaced and multifragmentary. The question then you will be asked is, how are you going to manage this patient? The scenario can be slightly different in the form of a smoker, IV drug user, running away from police with a very swollen and blistered foot. The two scenarios would have catered to different types of managements, and that's what we'll discuss during the course of this lecture. I would like you in your mind at this stage to formulate a plan how you would manage each of these two scenarios. And then we'll revisit that towards the end of the lecture to see if your management plan has changed. So during this session, we would like to know a bit more about the anatomy of the calcaneum, the epidemiology of calcaneal fractures, decision-making on when to operate and when not to operate. And if you're going to operate, then which surgical approach and which surgical technique are you going to use? Now, coming to the anatomy of calcaneum, the calcaneum is unique. It is partly articular. The superior surface is the posterior articular facet, which is the subtalar joint. Anteriorly, it articulates with the calcaneocuboid joint, and it also has the middle facet of the subtalar joint. The lateral surface of the calcaneum is flat and is generally targeted for fixation devices in cases of calcaneal fracture. And the medial side has the sustentaculum tali, under which pass the flexor tendons and the neurovascular bundle. Now, the important feature of this is that the blood supply of the calcaneum predominantly comes to the perforating branches on the medial side of the calcaneum, branches of the posterior tibial artery. So you need to be very careful in case you have to approach the calcaneum medially, which is common in open fractures where the sustentaculum tali pushes through the skin and creates an open fracture. The other object that you need to realize is the sinus tarsi region, which is between the posterior and middle articular facets of the calcaneum, and you get the sling of artery there, which are branches of the artery of the tarsal canal and the sinus tarsi, which then is the main blood supply to the talus. Now, a few angles that you will definitely be asked if you get a case of calcaneal fracture in the exam. First is the bowler's angle, which is created by the line joining the superior aspect of the posterior calcaneal process, the superior aspect of the posterior facet of the subtalar joint, and then the line joining between the anterior process of the calcaneum and the posterior facet. It is usually 20 to 40 degrees. The other angle is the crucial angle of Gissane, which is between the posterior facet and the line joining it to the anterior process of the calcaneum. It usually is between 120 to 145 degrees. Now, epidemiology-wise, calcaneal fractures comprise 75% of all foot fractures, 1 to 2% of the overall fractures. They commonly affect males, laborers, or people who have a chance of falling from height. You can sustain bilateral calcaneal fractures, and there is a significant evidence to support that patients who have workers' compensation benefit underlying do have a much poorer prognosis. In most places, the patient would take at least 4 months to return back to work, starting with light duties, and to get back to full previous employment, it generally takes up to 6 months. Now, if you get a scenario of a calcaneal fracture, first of all, you should start with the ATLS protocol, because to smash the calcaneum, it takes high energy. So you need to do a complete primary and secondary survey. 10% of calcaneal fracture patients would have a simultaneous fracture in the lumbar or dorsal lumbar spine. They can be a part of the polytrauma series. And the other important feature that you have to cater to is the soft tissues around the calcaneum. It may be either open fracture or having a lot of swelling, bruising, or blistering. All these would affect your management plan. The other thing that you have to explain to a patient of calcaneal fracture is the long-term implications of this injury. These can be associated with a long-term or maybe permanent pain, limp, and difficulty in mobilization. The foot shape or the heel shape will always be different, and accommodative footwear may be needed rather than off-the-counter footwear. The other important thing is the affection of the plantar fat pad. Whenever you get a calcaneal fracture, you would bleed into the plantar fat pad, which I equate it to a bubble wrap. And if you burst the bubbles of a bubble wrap, it does not work. So they can have long-term heel pain due to affection of the plantar fat pad as well. The second thing I tell my patients is it is similar to a Weetabix or a biscuit. If you smash a biscuit or a Weetabix with a hammer, it just explodes into multiple pieces, and it is extremely difficult to knit those pieces back. Now, when you get a injury to the calcaneum, the commonest mechanism is a fall from height, where you have forces of the body weight and the counteracting forces of the ground reaction force, where the heel impacts the ground. This causes a shear force which leads to the primary fracture line, which is generally passing through the subtalar joint. Now, depending on the intensity of that injury or the energy involved, you can get secondary fracture lines, which in a joint depression type of a fracture would exit just posterior to the subtalar joint, subtalar facet, but in front of the tendoachilles attachment. The other type of fracture commonly is the tongue depression type of a fracture, where you can have avulsion of the calcaneal tuberosity. Now, if you do have a patient with a tongue type of a fracture, it is important to give attention to the soft tissues. Sometimes there can be compromise of the blood supply to the soft tissues at the level of the fracture site. They may be blanched or they may necrose. This is one of the surgical emergencies, and if this is not decompressed immediately, then they can lead to skin necrosis over the calcaneal insertion of the Achilles tendon, which is very, very difficult to manage, and it's best attended to immediately, at least to reduce the tension on that skin thread. Now, the common classification that is used for calcaneal fracture is the Saunders classification. It involves the degree of comminution of the posterior facet of the calcaneum, which is seen in its broadest area in the coronal views. In type 1, it is undisplaced. Type 2 is major 2 parts. Type 3 would be 3 part, and type 4 would be 4-part fracture of the posterior facet. Now you will notice that the constant fragment is the sustentaculum talus. The other feature that you need to observe in this classification is if there is the increasing number of the classification, i.e. Grade 4 or grade 3 have more articular comminution, and obviously they would have worse prognosis because of the extent of articular damage. Now, how do we decide whether to manage this patient conservatively or operatively? The evidence says, the biggest paper being by Buckley, which had more than 200 patients in either arm in the randomized controlled trial between conservative management and operative management of calcaneal fracture. It showed that there is no functional uh, outcome difference between the two management options. The next, which is most commonly catered to in FRCS Orth exam, is the UK HEAL trial, which is available free access through BMJ. Again, the article showed that there is no difference in the functional outcomes of operative or non-operative management of calcaneal fracture, although the complications are much higher in patients who underwent operative intervention. There is long-term studies by Agren et al. Which showed that the operative management is not superior in the short term, but may be beneficial in the long term for calcaneal fracture management. The main thing that you would need to discuss would be the UK HEAL fracture trial, which was a randomized controlled trial, pragmatic, multi-centered, in which there were two arms, operative and non-operative. They had 22 tertiary referral hospitals included in that trial and 151 patients divided into the two groups, operative intervention being extensive lateral approach and the non-operative management option. They had a fantastic follow-up of 95%. They recorded no difference in the primary outcome, but the complications and reoperations rate was much more common in those who received the operative care. There was a high rate of wound complication, 20%. That is commonly seen in patients who undergo operative intervention with extended lateral approach. This generally was seen in almost all the newspapers of the United Kingdom when it was published, with broad headlines that calcaneal fractures do not benefit by operative intervention. Then the question comes, if you've got a young fit patient with degree of articular comminution involving the subtalar joint and reduction in the calcaneal height, I personally believe that he would do better with an operation, but the doesn't tell me that way. But if you then critically appraise the UK HEAL trial, you find that out of the eligible patients, only 30% of the patients were randomized, i.e. 70% of the patients did not be included in this study. The second was that there was only extended lateral approach used in this study. So effectively, it was patients where the surgeon and the patient were confused whether or not they would benefit by an operation, almost all of those patients were included in this trial. So there is a risk of a selection bias almost certainly with this trial. Now, in my hands, the patients with calcaneal fracture, who I think would benefit by an operative intervention, as long as the patient is reliable and would comply with your operative and post-operative management, then a patient who has got lateral wall blowout with calcaneofibular impingement, or where the calcaneal height is significantly shortened, where the posterior facet is significantly depressed, or there is significant deformity, i.e. varus or valgus deformity of the heel with or without calcaneofibular impingement. Now, if we come back to our scenario where we've got a young fit patient with an articular depression of the posterior facet of the subtalar joint, how are we going to manage this patient? Now, if we do decide that this patient would benefit from operative intervention, our aims of surgery would be to restore the calcaneal mechanics, i.e. the length, alignment, and rotation, which would be the calcaneal height, correct the varus deformity, control the tuberosity fragment where the tendo-Achilles inserts, and reconstruct the subtalar joint. Now, the gold standard for surgical approach to the calcaneum has been the extended lateral approach, which was described by Roger Atkins in 1992. It caters to the posterior peroneal artery blood supply to that area of the skin. If you do use this approach, I would like you to mark the skin where the skin color changes from dark to light and make it an L-shaped incision, go straight deep up to the bone and raise a subperiosteal flap. It is important not to raise a less thick flap because then the skin can necrose and it can be disastrous, even leading to amputation in cases of severe wound necrosis and infection. You then elevate subperiosteally till you reach the peroneal tendons. You reflect the peroneal tendons superiorly till you reach the posterior facet of the subtalar joint. Now, word of caution in this is that at the proximal and the distal end of this surgical incision, your sural nerve is at risk, so you need to be careful to protect it. There is almost 20 or more % of wound problems with extended lateral approach with extensive skin necrosis, which you should be aware of, and the patient should be consented accordingly. The other approach that is commonly used is the sinus tarsi approach, which is from the tip of the lateral malleolus to the fourth metatarsal. It gives you direct access to the posterior facet of the subtalar joint, but then you have to use indirect methods to reduce the calcaneal tuberosity fragments. Similar techniques will need to be used when you use an arthroscopic assisted calcaneal fracture fixation, where you should be able to see the articular surface quite well, and you can use that to reduce the posterior facet, but use indirect methods to correct the calcaneal width and height. They have both been shown to have lesser wound complication rates, and there is evidence of meta-analysis which shows that there's no difference in the radiographic outcomes between sinus tarsi approach and the extended lateral approach, but they have much lesser wound complication rates in the sinus tarsi approach. Now, if we get this fracture, whichever technique you're using, the basic principles of reduction of this fracture generally involve putting a shank pin or a spike into the posterior tuberosity fragment, use that to give traction, i.e. get that fragment pushed down to regain the calcaneal height. Next, you would like to reduce that posterior facet of the subtalar joint, i.e. you need to push it up and use the talus as a template to reduce this fragment appropriately. Similar techniques to what you would use for a proximal tibial fracture, where you use the femoral condyles as your template to reduce the tibial plateau back to normal articular surface. So what you would do in this case is that the posterior facet fragment would be elevated to get it congruous to the posterior facet of the talus, i.e. reconstructing the subtalar joint. On an axial view, the similar technique would involve pulling the calcaneal tuberosity fragment down to regain the calcaneal height, restoring the posterior facet of the subtalar joint, and then you have to use internal fixation devices, A, to fix the posterior facet, restoring the articular surface, absolute stability with interfragmentary compression device, and then you have to lag the calcaneal tuberosity fragment to the constant fragment, i.e. the sustentaculum tali, again using compression screws or plates. The essence is to restore the calcaneal height, correct the heel varus, get control of the tuberosity fragment, and reconstruct the subtalar joint. You then have to bolt these three fragments together, i.e. the sustentaculum talus, the posterior facet, and the posterior process of the calcaneum with some form of internal fixation device, whether it's screws, plates, doesn't matter. You have to reconstruct the Bowler's angle. So a reversed Bowler's angle has to be reconstructed to get it back towards normal, as well as cater to the Gissane's angle and reconstructed to get it back to normal. Otherwise, you would have impingement in eversion. You need to restore back the calcaneal width, because if you don't do that, you may compromise the footwear options for this patient if you leave the heel wide after the operation. So the take-home messages in this case would be patient selection, i.e. you need to have a patient who will comply to your post-operative regime. Smokers don't do well, so you need to carefully select the patients where you would offer operative intervention and who would then benefit from them. You need to have the necessary expertise. It is important for these fractures to be dealt by people who do them regularly rather than one-off, because these are difficult fractures and they have a high risk of complications in people who do not do these fracture managements regularly. The timing for surgery. Now, if you are going to use the extended lateral approach, then it is important to wait till the swelling settles and you get skin wrinkling in the lateral aspect of the heel. If you're using a sinus tarsi or an arthroscopic approach, it is important to intervene as soon as possible, preferably within the first 2 to 5 days. If you have to delay surgery for some reason beyond 2 weeks, it is extremely difficult to use the sinus tarsi approach to disimpact the fracture fragments and reduce the articular surface. If it has been delayed, I would recommend you to use an extended lateral approach rather than a sinus tarsi approach. So which approach to use depends on your expertise again, whichever you are conversant with. I personally use the sinus tarsi approach and I have a very low wound complication rate with that, but then I intervened soon after the fracture so that I can take advantage of that approach and reduce the risk of my complications. If you want an article to read about the general management of calcaneal fractures, the one listed below is a good review article to study about calcaneal fractures, especially if you're preparing for the exam. So in case you do decide operative intervention, the hallmark is restoring the calcaneal height and correcting the varus, stabilizing the fragment, a tuberosity fragment, and reconstructing the subtalar joint. If you do have any questions, there's an option of contacting me through my website. I'll be more than happy to answer your questions now as well as later if needed. Thanks, Gopal. I'll stop sharing.
Yeah, thank you, Dr. Kakwani. There is a brilliant presentation. Thank you so much. There were a couple of questions that were raised to me. One was, normally we wait for around 7 to 10 days, right, before we really intervene. We wait for the wrinkle sign. But
Yes.
is there any scenario, for example, if there's a tuberosity avulsion that's impinging on the skin, is there a scenario where we need to go using a limited approach and do it early? Because it's going to be going into necrosis, right? Otherwise, if we don't intervene.
Yeah. So as I said, in the tuberosity avulsion fragment, where you get compromise of the skin at the level of the insertion of the tendon Achilles, those are the ones which have to be intervened immediately, because even if you leave it overnight, the skin will necrose and it will be deep trouble after that. So in those cases, you need to intervene quickly. What I recommend is, if you don't have the expertise to deal with the calcaneal fracture primarily, then what you should do is, with minimally invasive like stab incisions, put a pointed reduction clamp across those two big fragments and just get that calcaneal tuberosity down. And if you have the expertise and the equipment, you could put percutaneous cannulated cancellous 6.5 screws across it. If nothing else, at least put the patient's foot in plantar flexion to reduce the tension in that area and get him seen by a person who can deal with it immediately.
Oh, that's great. And another one was, what is there any scenario where you'll be requiring an additional medial approach?
Yes. So the reason I did not purposely cover it is that if I don't want people to put a medial approach as their first form of management, there is a scenario where you get sustentaculum tali fractures, which are avulsed, or in cases of open fractures, you would use the medial approach. Now, if you have to buttress the sustentaculum tali approach, it is something similar to what you would use for the coronoid process of the olecranon. Any form of buttress plate would be fine for that, especially a one with a hook, which can then stabilize that sustentaculum talus fragment. In that case, you need to be aware of the neurovascular bundle. What I go through is the plane between the tibialis posterior and the FHL. The FHL will protect my neurovascular bundle behind it, and then you can approach the medial side through that. And sometimes, rarely, I have had to use medial approach in a closed fractures as well, if the fragment has a spike in that region which can compress my neurovascular bundle. To reduce that spike, I have used the medial approach as well.
Okay. I think there are no more questions, and this video will be archived. And
Perfect.
thank you, Dr. Kakwani, for spending your time. And to all the delegates who are there online, Dr. Kakwani is an established foot and ankle surgeon in the UK, and you can contact him. He has given his web address. You can go log in to drkakwani.com, and he'll address your queries. Thank you so much, Dr. Kakwani. Looking
Thank
forward for
you.
more. Thank you very much.